Welcome to the EAU podcast series, Present and Future of Diagnostics in Prostate Cancer. In this fourth episode, we are joined by Professor Eva Compérat and Dr. Rossella Nicoletti. Together, they will discuss why Gleason score 6 prostate cancer should not be renamed. Join us as we embark on this informative journey.
So good morning, everybody. I'm really pleased to be part of this podcast where there's a huge debate about renaming Gleason 6, and is it still cancer, is it not cancer? And I think it's really a very important debate. So my name is Eva Compérat. I'm a pathologist, so I defend the pathology side. Of course, I'm a neuropathologist, and I'm working at the Vienna Medical University for 4 years now, and I've been in France for nearly 30 years before. So it's a pleasure to be with you, and it's also a pleasure to give now the micro to Rossella Nicoletti, who will introduce herself.
Good morning, everyone. Thanks, Professor Comperat, for the kind introduction. My name is Rossella Nicoletti. I'm a urologist from Italy, University of Florence, and a PhD student. And today, I'm very glad to be here discussing these hot topics in urology about renaming the Gleason score number 6. So it's a pleasure to be here, and I can't wait to start. The first question that I would like to ask to Professor Comperat will be a very easy one. What is the Gleason score? What is the Gleason number 6, perhaps?
So Gleason scoring is, of course, I would like to say political, a very political thing. So Donald Gleason invented in the 60s the Gleason score, and this is something which really works pretty well. So Gleason score 6 is the lowest score you can get, which is a very well-differentiated tumor. What has to be said is that we really tried during all these years to update the Gleason scoring according to what the urologists and oncologists wanted to do, needed to know, and so on. And this is the reason why in 2005, 2009, and 2014, we really had very important meetings where we also included not only pathologists, but oncologists, radio-oncologists, urologists, so everybody who has to do something with cancer. And then we decided and voted together and discussed together these changes in the Gleason system. So now at the very moment, since 2016, we have what we call the modified Gleason scoring, which starts at 3 plus 3, so very well-differentiated tumors. Gleason 1 never existed, but at that time, when it was firstly described by Donald Gleason, he didn't have any immunohistochemistry, so he saw that adenosis was a very well-formed tumor, which was not true. Gleason 2 was abandoned for several reasons, so we start now with 3, as well on the biopsies as on the prostatectomies, and we know very well now that this is one of the reasons why we have this grade group. So grade group 1 is Gleason 6, and this is the best you can have. And we know if it's well treated, well handled, well survived, with a good surveillance, probably it's not a very aggressive and mean cancer.
So actually, I know that there is a relatively long story on this topic on renaming Gleason 6.
It's true, yeah, it's a very long story. So before we also had Gleason 2, which of course was Gleason pattern 2, which of course was pretty useful, especially in the prostatectomies. I think it really makes things simpler to say, well, it's just Gleason 3, and we put everything which is not very aggressive and well differentiated together. By the way, Gleason pattern has to be put twice. So we have, for example, a well-differentiated tumors over all the biopsies. So we have 3 plus 3, which is Gleason 6. This is why we have such a high number. One of the problems is that, at least in my experience, I have the impression that we have less and less Gleason 6. We have very many Gleason 7, 3 plus 4, very minor 4 in there, less than 10% sometimes, which makes it pretty difficult for us to call something Gleason 6 now. But if it's really Gleason 6, and it really exists, of course, then it really does not seem to be highly aggressive. On the other hand, we know that sometimes Gleason 6 can have a perineural invasion, can have extra prostatic growth. It's extremely rare. We all agree on that, but it can happen. And I think that's one of the reasons why we still should call it cancer, by the way. But
Yes, that's in fact something I would like to ask to an anatomopathologist like that is as good as you. So, from the pathological perspective, why, in your opinion, we should keep the name cancer for the Gleason number 6?
well, there are very many reasons. Of course, I mean, the pathological side has really put major arguments into the literature, I think. And the first one was, of course, Jonathan Epstein, who responded, I think, pretty well to these suggestions made by others like Matt Kupperberg and Scott Egener, for example, who wanted to abolish the name cancer for Gleason score 6. But first, I think Gleason grade group 1 can be indistinguishable from a higher grade cancer. So, and it's really, I mean, it lacks basal cells. So we really have the morphology, which will tell us this is cancer, and you cannot have any other arguments against it. So you lack basal cells. So of course it is cancer. We have molecularly, really, we have underpinnings which show pretty clearly that even Gleason score 6 is, of course, cancer. And I think if we would start calling it not cancer now, it would really be extremely problematic, inconsistent and confusion making in the prostate cancer reporting, because over all these decades we have called it cancer, and I think changing it now, we've already seen the problem with the grading in the bladder cancer. Changing it now would be really something which would lead totally to inconsistency. The second major problem is maybe you can sample, you do the biopsies, but are you sure that you have just really everything from the tumor? You can, of course, have sampling errors. I think it's also very well accepted now, this concept of active surveillance. So I'm really pretty convinced that patients can live with a diagnosis of Gleason score 6. We know that they have a very good diagnosis. Nevertheless, some people will die of these cancers, and we have seen this in several papers. And there was one paper recently published in European Urology Oncology in 23, where the Danish population study was made, and they could show that people do die of this cancer, even if it is Gleason score 6. So, but my major thing is probably that from a molecular point of view, Gleason score 6 is really cancer, and I'm really convinced that we have already shown this from a molecular point of view that this is really cancer. And we do not know very well why some patients who have initial Gleason score 6, 3+3, suddenly have a much more higher aggressive tumor. So there are some studies showing that you can have Gleason pattern 3 and nothing will happen, although you have an accumulation of molecular changes, and some of those will change, and we do not know very well why and when and how this happens. So therefore, I think it's really much more reasonable to call Gleason pattern 3 still cancer, although we know normally, let's say in 95 or 99%, it's not very aggressive.
So actually, you think that the molecular identity of the Gleason 6 can help us answer this question, right?
Yeah. Anyway, we're going more and more into all these molecular things now. And I think clearly Gleason pattern 3 is cancer from a molecular point of view. We have shown in a paper, it was published in 2018, so some time ago already, that according to the signature, the molecular signature which people have, even if they have a higher Gleason score, they can have a very good outcome. So obviously there's something going on genetically. And obviously, most of the time, of course, this happens with Gleason score 6. But nevertheless, you can also have this with higher Gleason. So I think we should go much more into the molecular pathways and have a look at what is going on there, than instead of struggling whether Gleason pattern 3 or Gleason score 6 is cancer.
So thank you for your opinion on that. I just want to add the urological perspective regarding the name of cancer, and actually I will give some thoughts on the word cancer, because from the urological perspective, I would like to quote a Scandinavian study that compared the quality of life among prostate cancer patients that were treated with radical prostatectomy and watchful weight, and a control group from a general population. And actually, the findings were striking. Regardless of the treatment received, simply having prostate cancer diagnosis was associated with a lower quality of life compared to general population. So actually, this specific study was quoted during the plenary session into 2024 during the EAU Congress by Professor Hamdi during a discussion on the PSA screening and the risk of overdiagnosis. And it was resonate beyond just screening. When we, as healthcare professional, clinician, anatomopathologist, diagnose patients with prostate cancer, and I think that actually this applies to cancer in general, we are giving them a label and a passport that they will carry for life. So actually, this diagnosis fundamentally change how they see themselves and how they experience life. So it's kind of a responsibility that we must always be mindful. So of course, as you brilliantly discussed, the pathological and molecular characteristics of Gleason score 6 and the oncological aggressiveness justify the use of the word cancer, but the introduction of the term clinical significant for Gleason 7 just, I think, partially addressed this issue because we need a broader reflection, and the mere use of the word cancer has a profound impact on patients' life and the quality of their life. So in the end, I think that we both agree that the Gleason number 6 should keep the name of cancer, but in the same time, we should be very aware that the name cancer can actually quite scare the patient and can affect their life. What do you think about that? What's your opinion?
Yeah, no, I agree. I mean, I'm not a man, so I will not have prostate cancer in my life anyway. But I can understand that people, when they hear the word cancer, obviously they're not very pleased about it. But on the other hand, I think it's really the question of it's the urologist who has to explain. Well, it's not very dramatic. Of course, we have to call it cancer, but you can have active surveillance and you will probably not die of your cancer. There are very many other, diagnoses where we say cancer, but we know very well these patients will never have any metastasis and they will have a very good outcome. Nevertheless, from a molecular point of view, it is cancer. And we never ever talk, when we talk about prostate cancer, Gleason score 6, about all these subtypes or histological patterns, which are, of course, Gleason 6, like the pin-like, which is a subtype, the pin-like cancer. Nobody asks whether we should call this cancer, yes or not. And it's a very low grade, not very aggressive cancer, and everybody calls it cancer. And we also call things like the intraductal carcinoma, and it's not even invading the stroma. So I think we should keep reasonably Gleason score 6 as cancer, but explain it very well, of course, to the patients.
Yeah, I think in the end, as from a pathological point of view, it's very clear the position. And also, I think from the urological point of view, it's quite understandable that probably we need some more time to spend to the patient with a Gleason 6 to explain a little bit more compared to the older Gleason score, what is going on, and the fact that rarely they will be affected in terms of life by this diagnosis, but probably they will be emotionally affected by the word cancer, perhaps more than be in fear of their life or the appearance of metastasis. So probably the key message from our discussion will be just keep the name, but probably take some more time to further explain to the patient what is going on. So it can be, so the word won't be so much scary for them.
I think that's a very nice conclusion. So, well, I think we have said more or less everything which is really very relevant, and I'm pretty sure that we will keep in the next years at least the terminology of cancer for Gleason score 6, but it's nothing to be really scared. And what I would like to add is, I mean, we do not have an international standard about active surveillance yet. So as long as we do not have that, for sure we will not move in our position from the pathology side.
Yeah, that's great. So we hope that there will be more collaboration in order to achieve an international way to handle those patients. So probably in this case, the name can be changed in a way that won't harm the patient's surveillance and the patient treatment and also the patient life. So thank you very much, Professor Comperat, for your expertise in this topic. I was very happy to be here discussing with you.
Thank you. Me too.
Thank you for this insightful episode. We are sure our listeners enjoyed it. To keep up with the latest EAU podcasts and stay informed on urological advancements, be sure to subscribe to our EAU podcast channel on your favorite podcast app. Until next time, keep learning and stay inspired.